Welcome to Ovarian Cancer 101. I'm Stephanie Blaufarb. I'm the Ovarian Cancer Program Director at SHARE. We're going to just wait 1 or 2 minutes more for people to sign on. I know it takes a little bit of time to sign on, so just hold tight for a few more seconds and we'll start the presentation. Okay, thanks for being patient. We were just taking a minute to let people sign on there. So I'll say welcome again. This is Ovarian Cancer 101. I'm Stephanie Blaufarb. I'm the Ovarian Cancer Program Director at SHARE. And before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a nonprofit organization that has been helping people through breast and ovarian cancer for the last 42 years by offering the support of those who have been there. SHARE offers many services, including a helpline, telephone and in-person support groups, and educational programs. And many of these are specifically for those living with ovarian cancer. All of our services are free of charge. For more information, you can visit our website at sharecancersupport.org. During this presentation, all participants will be muted. When the presenter finishes speaking, we will open up for a question and answer session. You are welcome to submit questions during the presentation through the question pane in the control panel on your screen. When asking questions, remember the presenter is unable to give specific medical advice, so please keep your questions general in nature. This webinar will be recorded and will be available on the SHARE website soon. So our speaker today is Dizon, Dr. Don Dizon. He is an oncologist who specializes in women's cancers. He is the director of women's cancers at Lifespan Cancer Institute and director of medical oncology at Rhode Island Hospital. He is also an associate professor of medicine at the Warren Alpert Medical School of Brown University. His research interests are novel treatments for women's cancers and issues related to survivorship, particularly as they relate to sexual health after cancer for both men and women. He is a prolific researcher and writer, and he has authored hundreds of publications, including peer-reviewed articles, books, and book chapters. In fact, he co-authored a book with patient advocate Dee Sparacchio called 100 Questions and Answers About Ovarian Cancer. We have copies in the office that we are giving away. So if you would like a copy of the book, please email us with your mailing address so we can send you a copy free of charge. The email address is webinars@sharecancersupport.org. That's webinars@sharecancersupport.org. All right, so thank you. Dr. Dizon, you can go ahead.
All right, thank you so much. It's always a pleasure to work with SHARE. They do some fascinating and important work. And they've asked me to give this introductory course to ovarian cancer. And I think it's a very important one because one of the things that I hear a lot about when I speak on the topic of ovarian cancer, especially hearing from women who have undergone the diagnosis and treatments themselves, is that you realize no one is born knowing what it's like to be diagnosed with ovarian cancer and to know what exactly the steps are, or in fact what the disease is. And it takes a lot to learn how to have ovarian cancer. And the education that comes along with being a patient is one that is almost harried at the point of diagnosis. And so while many of you may not have the diagnosis of ovarian cancer, or many of you may know somebody, or actually some of you may actually have the diagnosis, I hope this provides some clarity on what it means to have ovarian cancer today. So I'll do this in the spirit of the 100 Questions and Answers book that Dee and I wrote. And these are going to be 12 or so questions that I'll tackle for you today. The first of which is, what does it mean to have ovarian cancer? And this is important, particularly because when we first meet women who present with symptoms and undergo a CAT scan or other imaging that shows a potential issue within their body, particularly as it concerns the female gynecologic tract, they'll be told they have a variety of things, either ovarian cancer, they may hear they have peritoneal carcinomatosis, they may even hear something about their fallopian tube being the origin of cancer. And it all may be intermingled or synonymously used as ovarian cancer. And indeed, ovarian cancer indicates an invasive tumor that originates in the ovary. But importantly, it does include tumors that start in the fallopian tube and tumors that are involving the omental cavity or omentum of women or the peritoneal cavity. And you'll hear three terms as it relates to ovarian cancer: ovarian carcinoma, fallopian tube carcinoma, as well as primary peritoneal carcinoma. The cells of origin are quite similar in all three sites, which is why, lumped together, we treat them all as ovarian cancer. The most common of these is epithelial tumors of the ovary, and some of the most common types are high-grade tumors, or otherwise serous carcinomas. Serous carcinomas might be the most common, but there are other types of cancers that arise within the ovary, meaning primary cancers of the ovary. These can be endometrioid or mucinous histologies. A rarer one in the United States is a clear cell carcinoma, but there are other types as well, which include sarcomas of the ovary. Non-epithelial ovarian cancers can also occur. These include tumors of the germ cells, or some of these may be teratomas. Sex-scored stromal tumors or a granulosa cell tumor is one of these. Mixed mesodermal tumors like the carcinosarcoma. But among the ones that are non-epithelial origins in the ovary, perhaps the more common is to find a metastatic lesion from another site that involves the ovary at the time. So what are the risk factors for ovarian cancer? Most of our ovarian cancers that we find a risk for are due to hereditary mutations. So hereditary meaning it's a genetic change in your DNA that you inherited from your mother or your father. And these genetic mutations, although they account for a minority of cases of ovarian cancer, are still quite important for us to recognize, because it then becomes a way for us to screen you for treatments, but also your family members for risk. The one most classically associated with ovarian cancer involves mutations in the genes BRCA1 or BRCA2. These are genes that are involved in DNA repair processes, but there are other genes within this process or this pathway that can also be involved, and two of these are named here, are CHEK2 and PALB2. Beyond that, the family history can be very informative. So even if we do not find a genetic mutation, if your family history, again, in your mother's or your father's side, has a degree of cancers or even predominance of ovarian cancers, that is still very important to us. Among non-hereditary ovarian cancers, older age is a risk factor for the disease. This is a disease that is commonly commonly diagnosed in women in their sixth decade. Excessive ovulation, we think, due to the injury or the injury on the ovarian surface. But importantly, fertility drugs are not tied to an increased risk of ovarian cancer. So women who have undergone fertility treatments for reproductive purposes do not appear to have an increased risk of ovarian cancer. In terms of ovulation, the interesting point about that is it does point us to a way to reduce your risk, if this is a concern for you, by the use of oral contraceptives. What are the signs and symptoms of ovarian cancer? They are listed here. The symptoms tend to be very nonspecific, but there are two that have been reported to be target symptoms for ovarian cancer, and those are bloating and abdominal pain. How they established this was they looked at a cohort of women who developed ovarian cancer, compared them to a cohort of women with breast cancer and another cohort of women without any cancer diagnoses, and they looked back to see what symptoms these women had in their past. And it turns out bloating and abdominal pain were the ones that most clearly characterized women ultimately diagnosed with ovarian cancer. And of concern, these symptoms were actually present as long as 6 months before the final diagnosis was made. Other symptoms you might see is abdominal distension. That will be manifest in various ways, but it might be quite subtle, as women complaining of their pants no longer fitting them, or their pants getting progressively tighter even though they're not eating more, for example. Shortness of breath may be a sign of pleural effusions, which is water around the lungs that could potentially limit the expansion of the lungs when you breathe. For non-epithelial tumors, these tend to present because the ovary gets quite large with the tumor inside of it, so large, in fact, that it can twist upon itself and cause torsion. This tends to present as an emergency situation with abdominal pain, and may be a reason why women are taken to the operating room to help correct this condition. Number 4 is what blood tests can be used in ovarian cancer. And I purposely titled this in ovarian cancer because we do not have good blood tests to screen for ovarian cancer. But 2 of the more commonly used markers are CA-125 and HE4. CA-125 has been around for decades. For screening, there is a way to use it using something called the risk of ovarian cancer algorithm, or ROCA. However, 2 large clinical trials have been reported, one in Europe called the UK TOX trial. In the US, it's a PLCO trial. Neither of them showed a benefit to screening using this risk of ovarian cancer algorithm, which essentially use ultrasound and CA-125 in individual patients. And individual patients set their own baseline. So whatever your CA-125 is when you started the screening, each subsequent lab test you did was compared to that baseline test. So we don't technically use, or we should not be using CA-125 to screen for ovarian cancer, but when I see a woman who I think has ovarian cancer based on clinical presentation, I order the CA-125 not to make the diagnosis necessarily, but to see if it is a marker of her disease. Because if it is, then I can follow how she's doing on treatment and see if it's dropping or staying the same. If it's dropping, it's a very good surrogate marker for disease activity. Post-treatment, we do use the CA-125 as part of the surveillance strategy. Importantly, for anybody who has ovarian cancer in remission at this time, your CA-125 should be considered a measure of your disease activity. It is not a measure of volume, and it should not be used to help decide whether or not you require subsequent therapy. There was a very nice clinical trial that was performed in the UK by Rustin and his group, which essentially took women who were completing treatment for ovarian cancer and randomly assigned them to CA-125 lab draws where you were told the results, to blinded CA-125 lab draws where you were not. And when the CA-125 became elevated, half of that group were not told it was elevated. The other half were given that information, and treatment decisions were made. At the end of the day, women who had their CA-125s revealed to them started chemotherapy earlier and had a worse quality of life compared to those women who had their CA-125 blinded. However, earlier initiation of treatment was not associated with a survival advantage. So what we did find was we made women's quality of life worse with unblinding of the CA-125, but to no immediate benefit in terms of survival. So again, using surveillance as a measure of what the disease might be doing inside of your body. If it becomes elevated, it should prompt further workup or imaging before you decide on treatment. In terms of HE4, this is a test that was developed more recently, and it's used as part of the risk of ovarian malignancy algorithm. Richard Moore published this data, now 7 years old. And essentially the way to use HE4 is for women who are known to have a pelvic mass in whom their gynecologist feels that this requires operative intervention. And you can check an HE4 and CA125 and plug it into Roma to ask the question of who should do the surgery. And Roma will give you a high risk or a low risk of whether or not this might represent an ovarian malignancy. And if it does present with a high risk as an ovarian malignancy, a surgeon, a gynecologic oncologist, should participate in the surgery. That is how Roma is being used. There's some data suggesting it can be used in follow-up. Number 5 is the staging of ovarian cancer. And unlike lung cancer or other solid tumors, ovarian cancer is staged surgically using what's called FIGO, or the International Federation of Gynecology and Obstetrics. What I've listed here is the staging system for ovarian cancer and its American Joint Commission on Cancer equivalent using tumor nodes and metastases. And stage 1 through 4 essentially is what the surgeon sees when he explores your abdomen. So the first point is staging requires surgery. Oftentimes, for women who have a large extent of disease based on imaging or who are very sick from their cancer, we will not undergo, she may not undergo staging in favor of primary chemotherapy, or what's called neoadjuvant chemotherapy. And the goal of neoadjuvant chemotherapy is to reduce the volume of disease or make the patient stronger so she can undergo surgery at some later date, in which case the surgery is where the stage is set. And again, we use FIGO staging, which is on the far left here, stages 1A all the way out through 4B. You'll note a pleural effusion is designated as stage 4A disease, whereas disease that involves lung nodules or liver metastases or bony involvement is 4B. Number 6, when would you use chemotherapy first? I kind of alluded to this in terms of neoadjuvant chemotherapy. Neoadjuvant intends chemotherapy before planned surgery. The indications, again, high morbidity associated with initial presentation. So whether you're a woman who is incredibly weak due to cancer burden, unable to breathe due to the pleural effusion, or incredibly tense ascites due to the volume of disease within the abdomen, would render someone maybe too sick for surgery or at risk for significant post-operative complications. If the disease is too extensive, so it's involving a lot of the omentum, that you might lose your entire colon if they go in, or if there's an unavoidable delay to surgery due to circumstances out of the control of the patient, all of these might be indications to start with chemotherapy first. Importantly, we know primary surgery followed by chemotherapy, or a few courses of chemotherapy before surgery followed by completing that chemotherapy. But the survival is the same. What we get with neoadjuvant chemotherapy is less morbidity at the time of surgery, less complications, faster recovery, and less days in the hospital. Typically, if we do neoadjuvant chemotherapy, we'll do 3 cycles before an evaluation of surgical appropriateness. And the reason for that is simply that's been the standard used on clinical trials. So we haven't done randomized trials where women complete 6 cycles of chemotherapy and then go to surgery versus surgery alone, for example. So right now, the common recommendation is 3 cycles of chemotherapy prior to surgery, followed by 3 cycles of chemotherapy following surgery. And in terms of the criteria for the neoadjuvant chemotherapy, this is a very busy slide. These are the 4 randomized trials that were performed. It was summarized in a joint statement by the American Society of Clinical Oncology and the Society of Gynecologic Oncologists. The first author was Lexi Wright. And again, if you just look at the second column of enrollment criteria, you'll see that most of these had to have pathologic confirmation by biopsy, although some of these studies did allow enrollment of patients who had a very elevated CA125 compared to another tumor marker called CEA. And CEA is sometimes used to help follow or help confirm a diagnosis of a colon cancer. Our committee, which I was a part of in terms of the ASCO SGI clinical guideline, we felt that it would not be sufficient to use tumor markers alone, and felt you really should use a biopsy to show the diagnosis. And in the final column, you'll see what the the severe complications from surgery were. For women who got neoadjuvant chemotherapy on the first trial or Scorpion, huge reduction in complications with the use of chemotherapy. In the Chorus trial, again, 10% reduction in complications. In the Japanese trial, it was a third less. And in terms of the EORTC trial, again, a fairly substantial reduction in complications with the use of chemotherapy. Number 7 is, what exactly is a gynecologic oncologist? A gynecologic oncologist is someone who's done a residency in obstetrics and gynecology, followed by a fellowship in residency in obstetrics and gynecology, followed by a fellowship in this field. And that fellowship usually is 3 components, and it's very most basic. So there's always a requirement for some kind of research. It's obviously the surgical skills and the management of the woman with gynecologic cancer, but gynecologics are also trained in the medical management of this disease. So in some parts of the country, your gynecologic oncologist may be giving chemotherapy, and this is okay because it's part of their training. However, there are other specialists who may call themselves gynecologic oncologists, just like I do. And there are those of us who solely train in the chemotherapeutic and medical management of cancer and have opted to specialize in the treatment of gynecologic malignancies. So we are medical oncologists who do not do surgery but do treat gynecologic cancers. As well, there are radiation oncologists who have made it their career to treat women with gynecologic cancers. So again, these are all considered gynecologic oncologists, but in terms of surgery, surgeons who train in OBGYN, who did the fellowship, are what are indeed gynecologic oncologists. In terms of who needs chemotherapy, for women with epithelial ovarian cancer, most patients will require chemotherapy. There are some exceptions. If you are fortunate enough to be diagnosed with earliest stage of disease, meaning it is disease found within the ovary without involvement of the ovarian capsule. So it's a tumor that's absolutely confined to the ovary. Particularly, it's a non-serous histology, or if it's a low-grade tumor, we may not, and in most cases, will not give chemotherapy. Indeed, some non-epithelial ovarian cancers may not require treatment beyond surgery. But for women with early stage disease in whom chemotherapy is indicated, so this includes women with capsular involvement or 1C ovarian cancer, up to 6 cycles of chemotherapy may be recommended, and the chemotherapy of choice is a platinum paclitaxel combination. For women with more advanced disease, there are additional options for chemotherapy. So if you got neoadjuvant chemotherapy, say because of one of the indications that I previously talked about, we may continue just solely IV chemotherapy to a total of 6 cycles. We may put in a port and give intraperitoneal chemotherapy, even if you got IV chemotherapy initially. And more recently, there is some data suggesting there might be a role for heated intraperitoneal chemotherapy, which is done at the time of surgical debulking and before you go on to proceed with more chemotherapy through the vein. For women who underwent a primary surgical cytoreduction, it depends on whether or not there was disease left behind. And terms we usually will use is no gross residual, optimal cytoreduced, or suboptimally cytoreduced. And these are all terms that surgeons will apply to your specific case. If there is no evidence of residual disease, you become a candidate for intraperitoneal chemotherapy. But if there was suboptimal cytoreduction, meaning there was residual disease, usually it's greater than 1 centimeter within the abdomen, intraperitoneal chemotherapy may not be used or is not indicated in that case, in which case chemotherapy will be used with or without bevacizumab. So in terms of adjuvant treatments after primary chemotherapy or neoadjuvant chemotherapy, there's not been a good phase 3 randomized trial looking at this question beyond the HIPEC trial. So here you have the two neoadjuvant trials, CHORUS and EORTC, both of them performed in Europe. These two trials gave everyone a standard treatment of 3 cycles of carboplatin and paclitaxel. The PETROC study was a phase 2 randomized trial. It was designed to pick a, quote, winner. And here, after neoadjuvant chemotherapy, women were randomly assigned to either get IV chemotherapy or IP-IV chemotherapy. And that was decided only for women who had an optimal cytoreductive surgery. The heated intraperitoneal chemotherapy trial compared women who got neoadjuvant chemotherapy and who had an optimal cytoreduction to either carboplatin and paclitaxel for 3 cycles or HIPEC during the surgery, in which case they used cisplatin, followed by carboplatin plus paclitaxel times 3 cycles. And these were the results of the CHORUS, EORTC, and PETROC study. And I think the important thing to see here is that with the use of 3 cycles of carboplatin and paclitaxel, there was no real improvement in overall survival compared to just doing primary cytoreductive surgery followed by 6 cycles. In PETROC, we had a suspicion. Again, this is was not a large enough trial to inform standard of care. But if you look at the overall survival, the incorporation of intraperitoneal chemotherapy, this is reversed, the incorporation of intraperitoneal chemotherapy produced an overall survival of 5 years versus 38 months if you got straightforward IV chemotherapy, suggesting a role for intraperitoneal chemo, suggesting it. Now, this is the latest data that was presented by Van Driel and published in the New England Journal of Medicine. This is a trial of women with newly diagnosed with stage 3 disease who also underwent neoadjuvant chemotherapy. And at the time of surgery, they were randomly assigned at that point to HIPEC or no HIPEC. And after recovery, everyone was treated with 3 cycles of carboplatin and paclitaxel. What I'm showing you here is the surgical outcomes, and you'll see surgery with HIPEC added significantly to the surgical time, but the duration of hospital stay in days was quite similar, 8 versus 10 days, and the time to the first cycle of carboplatin plus paclitaxel was not changed. It was 30 days at median versus 33 days with HIPEC. In addition, the vast majority of patients were still able to receive 3 cycles of carboplatin and paclitaxel. There was no change in the adjuvant intent even after HIPEC was given. The results in terms of recurrence-free and overall survival are shown here, and what you're seeing is a shift to the right with the incorporation of HIPEC, suggesting a significant survival advantage for the use of HIPEC in women with an optimal cytoreduction who had received neoadjuvant chemotherapy. So this, again, was provocative. This is not expertise that's available anywhere or everywhere, but we are planning to seize upon this data and take advantage of some expertise we have at Lifespan and launch a program using HIPEC chemotherapy for women who are appropriate candidates for the procedure after neoadjuvant chemotherapy. So this is something that's exciting, and we're looking at this as a society of gynecologic oncologists. We're also decided to act on this data here in Rhode Island, again, because we have the expertise available. Number 10 is what exactly is the role of genetic testing for women with ovarian cancer? And that's listed here. So genetic testing, to be clear, is to test for inheritable mutations from your father or your mother, not just your mother, but also your father's line. And we use blood, serum, or saliva to do these testing. Now, what I quoted here is Norquist data from the University of Washington, the mutation frequency for BRCA1 or 2 was still the far most common in this cohort of patients, about 15%. But you saw other mutations in the BRCA pathway about 3% of the time. MMR is mismatch repair deficiencies, and these are important because now we have the availability of immunotherapy for women with MMR deficient tumors. Now, when Norquist tested the data on ovarian cancer, the mutation frequency from mismatch repair was less than 1%. And here she breaks down the mutation frequencies by histology and stage, by age of diagnosis, race, and ethnicity. And still, the darker colors represent BRCA1 and BRCA2, and they still are by far the most common mutations picked up. This is the types of panels that are also available for genetic testing, and it's quite comprehensive, and it can go by a breast ovarian panel all the way up to a multi-cancer panel or a more comprehensive panel that tests far more genes than just, say, BRCA1 and 2. The stratification of when to select one or the other type of test is really a complicated one. So in our institution, we will oftentimes rely on the advice of a genetic counselor in terms of which test should be used. So test in most centers, we're testing at the point a woman is diagnosed. This is supported by both the Society of Gynecologic Oncologists as well as the NCCN. If resources were more limited, you can stratify the importance of testing based on histology, and we will generally test high-grade histologies in those women with serous carcinomas. I alluded to this in the beginning, but the rationale for testing at the point of diagnosis are the implications for the family, both the immediate as well as the extended family. And it may also inform treatment options, maybe not today, but in the event of a relapse. And also may open up discussions of secondary prevention, particularly as it relates to BRCA mutations. If we're treating you for cure, would it make sense to then undergo prophylactic surgeries, i.e. prophylactic mastectomies? All of these are points of discussion that can take place for women who we find a mutation present. Now, in contrast to genetic testing, there's a whole discussion on genomic testing and when should that be done. Genomic testing is to test your tumor for mutations which are not inherited by your mother and your father, or from your mother and your father. These are mutations that are found within your tumor. And whether or not to test, I want to just bring up two very small studies, one from the U.S., from San Diego, and one from Thailand. The bottom line here is that even with genomic testing, only 1 in 5 women in 2 separate studies were receiving treatment based on the genomic results. So in terms of when should you test, although it is available, genomic testing is not mandatory for anybody. So we should not be ordering it with you just to find the information. We should be using genomic information so we can find a more appropriate treatment for you. And this is where the concept of basket studies become important. So basket studies is where they're studying a mutation, for example, but in different cohorts of patients. So there could be a cohort for lung cancer, there could be a cohort for patients with prostate cancer, and there could be a cohort for patients with ovarian cancer. That ovarian cancer basket might be reason enough to do foundation or other types of genomic testing. And the reason to use this is also to ensure we have a better understanding of the frequency of these actionable mutations that are covered now by an FDA-approved agent. Again, mismatch repair deficiency is a good one. Now we know less than 1% of the time are we finding these across ovarian cancers. Number 12 is for women who relapse, how do we make decisions alongside of you? And we do it based on the PFI, or the platinum-free interval. And what I'm showing you here is that as the interval increases before the detection of recurrence, that is not only prognostic, but predicts how you would do if I retreated you with a platinum. So in the boxes, you're seeing the response rates for platinum retreatment. And the longer the platinum-free interval, the higher the response is going to be. And the longer that interval is, the higher the progression-free survival after treatment is going to be in the green line. And also it's associated with an improvement in overall survival as well. So from this graph, you can learn that the longer your platinum-free interval, the longer your chances of having a progression-free survival, and the longer you are expected to survive your cancer. How do we choose these treatments? It's based on preferences, tumor burden, and the platinum-free interval. So preferences is where we as doctors need to listen to what you're telling us in terms of what are your priorities as we move forward. What are your goals and your preferences? It might be something as important that you do not lose your hair, or it might be important that you be able to wear the shoes you really love, or that you be able to play the guitar. All of these are important factors we can keep in mind. And we can balance that by the tumor burden that you are experiencing right now. Is it by the volume of disease? Is it manifest by symptoms? Or is it worsening your overall performance status or your ability to take care of yourself normally? Number 12, and I think this might be one of my last slides, are what are the new agents that have been approved? And the PARP inhibitors have created quite a splash because of the successive approvals of 3 drugs on market right now. The indications differ. This is the first I'm going to show you is the indications in maintenance treatment. So maintenance treatment means a woman has recurred. They were retreated with platinum-based drugs. They experienced a response on chemotherapy. The chemotherapy was subsequently stopped, and they were then proceeded on maintenance PARP inhibitors. And in that setting, for women who have had a response to retreatment with platinum, niraparib, olaparib, and rucaparib are all approved. Now, for the maintenance setting, none of these drugs require mutation status. Now, when you look at PARP inhibitors as a treatment line, so you have recurrent disease, you have progressed from 1, 2, 3, or even 4 lines of therapy, and you want to use a PARP inhibitor, olaparib and rucaparib have those approvals. Olaparib, however, can only be used for treatment in women with a known mutation of BRCA that she inherited from her mother or father. So you have to have a germline mutation, and the approval is after 3 lines of prior treatment. For rucaparib, you can have a germline mutation, or you can have a mutation in the tumor. So you can have either a genetic or a genomic mutation in BRCA and get rucaparib, or you can have another finding on the tumor called homologous recombination deficiency. So if you have evidence of HRD, you are a candidate for rucaparib, and rucaparib can be used after 2 prior lines. The mechanism of these drugs is to help prevent DNA repair. Now, the reason this is so important in women who have that known mutation BRCA is because they do not have homologous recombination capabilities. They rely on PARP to repair DNA. Now, when you put that drug, a PARP inhibitor that blocks PARP, then these cells in women with a mutation no longer have the ability to repair themselves, and it drives them towards cell death or apoptosis. This is, again, a summary slide for the indications. As maintenance treatment, none of these drugs require you have a mutation present because you're using it to maintain the response you receive on platinum taxane for recurrent disease. Now, if you're going to use olaparib or rucaparib as a treatment line, you need to prove the existence of a mutation in the germline in the case of olaparib, or germline or somatically in the case of rucaparib. When should you use these drugs and who should get these drugs? Patient selection is quite important. You want to use these drugs in women before they run into trouble with their GI tract. And we generally want women with a good performance status to take these drugs because compliance can be an issue. It has been suggested that women who required frequent dose delays or modifications on chemotherapy due to myelosuppression may not do well on PARP inhibitors because even though these are pills, they can be quite toxic, especially to the bone marrow. Most of our clinical trials have also enrolled women with high-grade serous carcinomas rather than endometrioid or low-grade mucinous tumors. So there's a suggestion that we should only be ordering these women with serous histology tumors, although this is not a part of the indication. No genetic mutations and then good organic function. When to use it depends on the platinum-free interval. What I'm showing you here in orange is women who had platinum-sensitive known BRCA mutation carriers. And what you're seeing is that across lines of therapy, provided they continue to be platinum sensitive, they will respond to treatment at any point. However, if you have a germline BRCA mutation and you develop platinum resistance, you're going to want to use these drugs as early as possible to take advantage of the higher response rate. And then finally, is there hope? What's coming down the pipeline? Clinical trials are ongoing, and these are quite important for us to make these strides. All of the drugs that I've talked about today have only been approved because women have participated on our trials, but these are some of the more intriguing ones that are currently on trial. Mirvetuximab somatropin is a folate receptor antibody coupled with a very potent microtubule inhibitor, and it's in phase 3 for platinum-resistant ovarian cancer against standard chemotherapy. Regarding immunotherapy, there's no real good data that it's going to be effective as a single agent. But in an earlier clinical trial, we saw a signal in clear cell cancers, and here at Brown Oncology Group, we're about to activate a phase 2 trial for women with ovarian clear cell carcinoma using the immune checkpoint inhibitor nivolumab with or without CTLA-4, a different type of immunotherapy, ipilimumab. And then we're looking at PARP inhibitor combinations that are using either anti-VEGF drugs or other kinds of immunotherapy in clinical trials. So for more information, I would point you towards the third edition of 100 Questions and Answers, which Cher is graciously offering anybody on the webinar. But thank you very much for having me, and I'd be happy to take any questions.
Great, thank you. So now let's start the Q&A. So I wanted to remind everybody that you can submit questions. There's a little drop-down box that says questions on the GoToWebinars pane, and you can click on that and you can submit a question while we're talking here. And if you do not hear your question, you can also call the helpline and talk to a trained survivor who may be able to help you find your answer. Our first question that was submitted, this person is asking if there's a correlation between dairy intake and ovarian cancer.
To the best of my knowledge, there's no association with dairy intake and ovarian cancer. But the issue, interestingly, does come up for women on chemotherapy only because GI distress is quite common with ovarian cancer therapy, and some of our drugs, particularly carboplatin, some of the medication we use to prevent nausea, can cause significant constipation and abdominal pain. Oftentimes, I'll ask women to be careful what they eat in terms of GI tract motility, and sometimes I am finding, at least symptomatically, some women are developing a degree of lactose intolerance. So that's the only time that I do sometimes ask people to think about whether or not lactose is causing some of their GI distress. But in terms of pathogenesis or progression of ovarian cancer, no, there's no good data at all on dairy products in ovarian cancer.
Okay. I mean, there are a lot of myths about what causes ovarian cancer. Is there any other, just since that person asked, it makes me think, do you know of any that you'd want to take the opportunity to dispel? I've heard of people concerned about birth control pills or anything like that.
Yeah, so we did cover that. So birth control pills are actually quite interesting as a way to reduce your risk of ovarian cancer. So definitely it's not been implicated as a cause for ovarian cancer. Again, fertility drugs, not associated with a risk of ovarian cancer. And then more controversially has been talc. So the data has been suggested that talc can cause ovarian cancers. But I think the totality of the observational data, because clearly there's no experimental model where we injected talc into women's vaginal vaults to see if they developed ovarian cancer. But the bulk of the observational data do not support talc as a causative agent in ovarian cancer.
Okay. And somebody was asking about prophylactic removal of ovaries and fallopian tube. Which types of patients would this surgery be worthwhile looking into?
So for right now, we are recommending prophylactic BSO or bilateral salpingo-oophorectomy, which is removing of both ovaries and tubes, only in women with a known mutation in BRCA. That's being extended out to mutations where there's an associated risk of ovarian cancer, so check to PALB2 mutations as well. It's still not something that's being suggested women with normal risk, so general population, undergo. However, there's a very provocative discussion ongoing, and I think that's still under an observational study in Canada, and it's called opportunistic self-injectomy. So what they're doing there is they're targeting women who are getting their tubes tied, for example, or undergoing hysterectomy for non-cancer reasons, and surgeons may ask you to consent to removing just your fallopian tubes at that point. And the opportunistic comes because you're doing a surgery in the pelvis unrelated to ovarian cancer, but will take advantage of this time to remove the tubes only. And the reason that this has come into conversation is because it appears that for a lot of ovarian cancers, the precursor lesion may be at the fallopian tube. So removing the fallopian tube might be a way to prevent ovarian cancer, although you're going to need a huge data set and huge follow-up to even demonstrate that that's actually true. But opportunistic self-injectomy is something that's being done.
Okay. For women who have had breast cancer, is there an increased risk of getting ovarian cancer?
Actually, there isn't, outside of a genetic mutation that runs in the family. So there was some earlier work went into the family histories of women with breast cancer only who had tested negative for mutations in BRCA1 or 2. These women are not at increased risk of ovarian cancer.
Okay. Are any women, this is the question is written in quotations, cured of ovarian cancer?
We do actually cure. So I will tell patients that I'm meeting for the first time, whether they have, stage 1, 2, or 3 disease, that if you are able to undergo a successful surgery, my role to give you chemotherapy is to give with curative intent. Now, at the end of the day, that's probably on the order of 15% of women are cured of ovarian cancer. We just cannot tell who is in that group.
Right. Okay. When is the best time for someone diagnosed with ovarian cancer to seek a second opinion?
I'm sorry, can you say that again?
When is the best time for someone diagnosed with ovarian cancer to seek a second opinion?
Whenever one thinks about it.
Yeah, okay.
So I always encourage second opinions. I put it this way. The person who requires the best treatment is not the doctor. It's the person who's getting the diagnosis. So you need to feel incredibly comfortable with your treatment team. And if there's a question at all, remember, it's your life and it's your body and it's your health that we're talking about. So you should feel very empowered at any point to get a second opinion.
Okay. And when is the best time to consider a clinical trial?
I think it's always appropriate to consider clinical trials, at least just to understand what the landscape of clinical trials are. It's a very personal decision on whether or not one wants to do a trial. But we still have ways to go to cure ovarian cancer. So if there is a question that seems reasonable to you, then I would hope that your physicians offer you that trial and that you would consider it.
Okay. And what is your opinion about consuming sugar if you have a normal weight? I'm assuming this is somebody who's already been diagnosed with ovarian cancer.
So, I think the whole idea of sugar is incredibly complicated. It has to do with insulin growth factor. Number one, ovarian cancer and its relationship to obesity is not entirely clear. And that's definitely not as clear as it is with endometrial cancer. So the fact that you're a normal weight person lets me know that you are aware of the obesity epidemic and the risk of cancers being diagnosed in women with obesity. Now, ovarian cancer, again, might have a link, but it's definitely not as strong as it is with some forms of endometrial cancer. In terms of sugar uptake, my advice to women in terms of diet is to follow a heart-healthy diet. So moderation is quite important. The thing about tumors is that they can create their own sugars. So starving yourself of sugar may or may not do anything in terms of the behavior of your cancer at all. It's been very difficult to prove that show at all any impact from dietary interventions in terms of ovarian cancer survival. So heart-healthy diets, we have to remember that even among women with cancer, the number one killer of women is still heart disease.
Okay. So for women who have been diagnosed with ovarian cancer, have gone through treatment and have no evidence of disease, what are some guidelines they can follow it looks like they're looking for advice to reduce the chance of recurrence in this question?
Yeah, right. I think it's going to sound almost self-defeating, but I think some of the things you can do is follow your health diligently and see your doctor at the intervals as prescribed. Typically, it'll be every 3 months for the first 3 years, and then to check your CA-125, but not do any imaging because imaging in the absence of symptoms is probably not going to be helpful. Things you can do proactively, are really in terms of addressing a couple of the psychological sequelae that comes with the diagnosis of ovarian cancer. So we know fear of recurrence is incredibly common after a diagnosis of ovarian cancer, and we also know that the complications of treatment can last longer, even beyond the end of therapy. So the objectives after treatment is going to be to try to gain control back of your life. So if fear of recurrence is an issue, there's some very nice data now available that psychotherapy or counseling and getting help, whether that be cognitive behavioral therapy, can provide that sense of control back. If you're having issues related to survivorship, seeking help for those issues is important. And then following a healthy lifestyle, whether that means continuing on with low-impact aerobics or a regular gym regimen is important. And again, a healthy diet in terms of low meat intake, high vegetables and fruits, reductions in alcohol consumption. All of these are overall globally healthy things you can do to keep yourself healthy and recover from the side effects of treatment. Regarding the preventing recurrence, that's still an area of exploration. I can't point to any specific advice that will reduce your risk of recurrence from ovarian cancer, but certainly we can point to many things that can help you gain some control of the situation following treatment.
Okay. One more question on that topic. Is there any difference in the symptoms of recurrence versus an initial diagnosis? Is there anything different that women should look out for?
Well, actually, so the vast majority of women who present with recurrent disease will present with bloating or abdominal symptoms. Sometimes you'll see shortness of breath or even breathlessness, which can point to a more serious condition like a a blood clot in the lung or a pulmonary embolus. Rarely are we going to see evidence of headaches or seizures or memory changes that will point more concerningly towards a brain metastasis or a brain tumor. That's rare. And typically we see that in women who have lived quite a long time with their ovarian cancer, certainly over 12 months or longer. So most of the symptoms will be manifest with abdominal symptoms.
Okay. At what point should palliative care become part of the discussion of treatment or become part of the treatment team?
Yeah, palliative care really should be looked at as supportive and symptomatic care. In my own practice, I start mentioning it early. So women diagnosed with stage 4 disease, certainly involving the liver and the lungs, and then women who are facing a first diagnosis of recurrent disease, it's a very good time to involve palliative care, not for end-of-life care, but for support and symptomatic management as you undergo treatment for the second or greater time.
Okay, great. There's recently in the news a report that chlamydia may be a risk factor for ovarian cancer. Do you know anything about that, or can you speak to that?
I'm sorry, say that again. Again, I know risk factors, but what was the first part?
Chlamydia as a risk factor.
Yeah, I don't believe that we have any good data at all to suggest there's an infectious association with any of the STDs in ovarian cancer.
Okay, last question. You did speak about CA-125, but we got a question about it, so I wanted, and it is certainly something that a lot of people often have questions on. Can CA-125 be used to detect ovarian cancer in an initial diagnosis?
Well, so if women are presenting with symptoms suggesting ovarian cancer, a CA-125 can be very useful, particularly if it's elevated. However, it does not supplant or should not be used in lieu of a biopsy to prove, tissue-wise that this is a cancer of the ovary, fallopian tube, or peritoneal cavity. In the woman who is doing fine, exam is completely normal, no symptoms, the pelvic exam is completely normal, in that situation, the CA-125 has a very limited role right now, particularly in women without a mutation in BRCA. But even in that population, we haven't shown definitively that screening with CA-125 and ultrasound is very helpful.
Okay, so it's not used in the general population for screening, is what you're saying, yeah?
Right. If someone is coming in with symptoms, though, it can be useful.
Okay, great. Thanks for clearing that up. Okay, so that's all the questions that were submitted, and I'd like to thank Dr. Dizon for an informative program, and thanks to all of you for participating and for submitting questions. Again, if you'd like a copy of the book, 100 Questions and Answers About Ovarian Cancer, please email us at webinars@sharecancersupport.org. That's webinars@sharecancersupport.org, and we will send you a copy free of charge. Please take a moment to fill out our survey at the end of the webinar. It may take a minute for the survey to download, and that will really help us bring you more programming. Thank you, and have a great rest of the day.
Thank you very much.